Thank you. As was expressed, my name is Judette Lewis, and I am representing the Society for Maternal-Fetal Medicine, and I would like to talk to you a little bit about how the data gets translated into practice. So the first question is, what is a maternal-fetal medicine physician? These are physicians who, after undergoing 4 years of medical school, trained for 4 years in obstetrics and gynecology, and then they decided that wasn't enough, or they're putting off the real world for a little bit longer. So they do an extra 3 years of training in just how to take care of pregnant moms and their babies. So when you look at what we do as maternal-fetal medicine physicians, it could be taking care of women who came into pregnancy healthy, but then got sick or developed a complication, or it could be moms who started pregnancy sick and needed extra care. But we also are uniquely qualified to take care of their fetuses. No one else trains in how to take care of babies when they're in utero. So when you look at what a maternal-fetal medicine physician does, I like to think of us as superheroes because, quite frankly, who wouldn't want to be a superhero? But we're also recognizing that our role should be more than that it shouldn't be just dealing with the acute emergency, but that we also have a role in making sure that moms stay healthy for the rest of their lives and also come into the next pregnancy healthier. And that's where data helps us. The other tool we have to help us is the Society for Maternal-Fetal Medicine. That's our organization that provides support for us in terms of basically giving us tools with which we can use to get information out to the other physicians and the healthcare professionals who take care of pregnant women about what is the right way to manage these women who have complications. The Society for Maternal-Fetal Medicine also fights for us in terms of those legislations that will help our cause and things that are important to us, but then also providing knowledge and research to everyone. So when it comes to maternal mortality, we're talking about the death of a woman while she's pregnant or within 1 year of pregnancy. It's irrespective of the duration of that pregnancy or the site of the pregnancy. And it could be from any cause that's related or aggravated by the pregnancy, but certainly it doesn't include accidents or incidental causes. And that's important for us to basically delineate because we want to focus on those things that are truly related to the health of the woman and could not, and not things that were incidental. It's important to know that in the US, the rates are rising, the rates of maternal deaths are rising, and it's surprising considering how much money we spend on healthcare, period. But also important to the people who practice maternal-fetal medicine is the fact that there are large disparities. And we all agree that whether or not you survive childbirth should not depend on where you live. And that's urban versus rural, or it should not depend on your race or ethnicity. And in this country, it does appear to be related to that. In terms of these committees, what they do is basically on a state level say we're going to review every maternal death. We're going to use whatever data we have, not just vital statistics, but actually review the case, get the records, and see what happened so that we can figure out why this woman died, what were the contributing factors, and what were the gaps in her care that could have contributed to what happened. There's very much a need to make sure that that process is standardized everywhere so that you're gathering all of the same information, so you're comparing apples to apples. But then when you get that information, what's very important is what you do with it next. And what we have been able to do is to say, well, these are the top causes, these are the things that are going wrong, and this is how we're going to intervene. And so much like the aviation system, we can use things like checklists to say, well, this went wrong because someone missed a couple of steps, and so here's a checklist to remind you that if you're encountering this scenario again, you need to do all of these things to make sure that this woman is properly cared for. There are also bundles, which are just simply a bunch of things that need to happen together if you're taking care of a certain condition. Again, it prompts people to be, to remember all of the steps. And, someone who's a little bit more utopian may say, why wouldn't, someone remember all of the steps? Well, a lot of these causes of death are uncommon occurrences that, yes, for most people, pregnancy still is a safe and benign, although painful, messy process. So for most of the time it goes well. But when it doesn't go well, you sometimes do need a prompt and a reminder of what are all of these, the proper steps to undertake so you can actually improve the outcomes. So these reviews are part of a greater system, right? So we do the reviews, we get the information. That information can then be sort of a tool for the perinatal quality collaboratives so that they know what to target. Perinatal quality collaboratives are just groups of people who have the common goal of improving outcomes for moms and babies, and they include nurses, physicians, social workers, public health professionals, just really anyone who can fit under that umbrella of perinatal care. And they put together these initiatives so that they can help people in hospitals as well as clinics to take care of these pregnancies in the right way. The other person who comes into play is the Alliance for Innovation on Maternal Health, and they likewise are a large organization of people from multiple disciplines who come together and put together guidelines that then they help get out to the practicing providers so that they have information on the right way to manage these people. So just to give you a little bit from the state of Florida, where I'm from, on how we're doing in terms of maternal mortality and what we're doing about it. So as you see up there, we rank number 36, nothing to be proud of. I can be proud of our beaches, but not this. But we recognize that it is a problem. And we have a lot of interest and passion about trying to improve healthcare for women there. So we currently have maternal mortality reviews, and we've had them for some time, and they're funded not just by the state but also private organizations and the American College of Obstetricians and Gynecologists. All of them work together so that they can review every death of a mom, and they try to do it in a timely fashion after which it has occurred. And people who participate are basically volunteers. They don't get paid for it, and in fact, they pay for their own travel so that they can get to these meetings. If you look at our data over the past years, I think it's important to note a couple of things. That when you look at the overall mortality rate, which is the line in black, that we're at the lowest rate that we've been in a number of years. But I think also important to note is that gap, that in green are non-Hispanic whites, in blue are non-Hispanic blacks. And we're looking at not just, it's not enough to just reduce that rate. Yes, we're at the lowest rate we've been, but look at that gap. There's still a huge gap. And so part of our goal is also decreasing that gap because, again, as I said, who you are should not determine whether or not you survive childbirth. So what do we do with that data? When we get the information from those reviews, we basically get the information out to the providers so that they know something, they know what did we find in the data and what are the areas that they should be focusing on. So they get newsletters, they get alerts if anything urgent is going on. They get letters sent to the hospitals so that the hospitals know what the top causes of death were and what they can do about it. And they actually publish their findings also in the literature. The Florida Perinatal Quality Collaborative is a statewide partnership that was started in 2010. Currently, we have 2/3 of all of Florida's births are covered under our collaborative, meaning they partake in our initiatives. And basically what we do is we focus on the data from the committees to tell us what are the top causes of deaths, and then we come up with these initiatives that provide the people caring for these women with tools so that they can improve how they manage them. So just to give you an example, these were our top causes of death: hemorrhage and hypertensive disorders. So we decided we're going to focus on those two conditions. This is a busy slide, but this was data from our hemorrhage initiative. So OHI stands for Obstetric Hemorrhage Initiative. And what we did was say, we know hemorrhage is the top cause of death. We asked hospitals to volunteer to enroll in this program where we taught them how to identify hemorrhage, because you can't fix what you don't identify, how to manage them, and then also how to prevent them. And so we wanted to know what percentage of the hospitals were even identifying patients who were at risk for hemorrhage. And so in green are the hospitals that said that 75 to 100% of all of the women who gave birth were assessed for their risk. By the end of our initiative, you saw that green bar increase substantially, where there were a lot more hospitals that were assessing almost every patient that came into their system. So again, showing that if you target something and you give them a way to work towards it, that the hospitals definitely could improve. Well, what about their measurement of blood loss, right? It sounds like a no-brainer. How come we don't measure blood loss? Well, typically we do what we call an estimated blood loss, meaning we look at it and we say, oh, we think it's this much blood loss. But there are actually ways to quantify the blood loss because, again, if you quantify it appropriately, then you know when to intervene, when to step up your treatment, or even when the patient may need a blood transfusion. At the start of the initiative, only 4% were quantifying the blood loss for vaginal deliveries. By the end, 62%. So again, we saw change. To move over to a different initiative we did was the hypertension initiative. Hypertension remains one of the top causes of maternal death, in part because their hypertension is not being treated quickly enough, and we know that the hypertension should be treated within 1 hour. So we looked at baseline before our initiative. Only 7% of the hospitals were treating all of their patients within 1 hour. By the time we ended the initiative, 63% were treating them appropriately. So it's not the 100%. And you know, there's no intervention that you're ever gonna do that will give you 100%. But again, it shows that if we focus on something, we can at least make some strides. We can educate the hospitals and their staff about the appropriate way to treat these patients. But also important is the education of patients. Because truly, most of the time when women die, they don't die during that same, admission where they delivered their baby. A lot of them go home and they have symptoms and they're worried about their babies, and so they're ignoring their own symptoms, or their family members are telling them, oh no, that's fine, you're supposed to be tired, you're supposed to have a headache, and they listen to them and they don't come back and get care soon enough. Or they reach out and call their doctor and their doctor doesn't listen to them. There are a lot of things that go on, but we realize that that's the most important time period so that they know when to come back in. So for part of this initiative, we asked the hospitals to actually give the patients discharge education so that they know when to come back for help. And so again, in the beginning, only 26% of the hospitals were, had most of their patients getting it. By the end, 92%. So our initiatives were doing what they were meant to do, to make sure everyone knew the right thing to do. But again, we could only do that if we get data, and the data has to come from all of the states, not just the few who have decided that it is important to them. So once we get accurate data, we can work on this more closely. The Society for Maternal-Fetal Medicine is also working on it. This is an example of a fact sheet that we're trying to get for each state. We did not come up with these rankings. We're using existing rankings out there. But the point is that we want each person to be empowered and to know what their state is doing to help decrease maternal mortality. There are these 4 key things that we think are important to decreasing maternal mortalities, and that includes things like having the review committees, because that's an important first step. Having perinatal quality collaboratives, which most states have them by now, but also reporting the rates by race, because you can't affect the disparity if you don't know that it exists. And of course, Medicaid expansion, which would help cover more births across the country. And I just want to give a quick example of how having that data also helped us on a local level, where when we were looking at hemorrhages, and we saw a huge disparity where if you had a hemorrhage, if you were Black, you were 4 times as likely to need a blood transfusion. And when we took a deep dive into that data, we saw they were being treated the same way. They received treatment in a timely fashion, they were identified, but that the actual difference was that they were coming into the hospital more anemic than their counterparts. So If I had started an intervention based on the hospital, it would not have cured that disparity because I wasn't really getting to the right problem. So again, the data helps you get to the right problem so that your interventions are effective. So what we're asking is for support for any of these legislations that will help us reduce maternal mortality, but the first step in particular is this legislative bill that will actually make it easier for states to collect their own data. Thank you.